Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 160 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, which of the following best describes the therapy most associated with the development of hypogammaglobulinemia? Is it A. fludarabine, or B. antithymocyte globulin, or C. rituximab, or is it D. alemtuzumab? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. rituximab. Alemtuzumab is a humanized monoclonal antibody that targets CD52, which is expressed on most normal and malignant B and T lymphocytes. As such, alemtuzumab is associated with prolonged and severe lymphopenia. That makes answer D incorrect. Similarly, antithymocyte globulin acts on T-cell surface antigens to deplete lymphocytes, leading to prolonged and severe lymphopenia. That makes answer B incorrect. Fludarabine is a purine analog that inhibits DNA synthesis in lymphoid and myeloid malignant cells. Purine analogues also attack resting lymphocytes, resulting in prolonged lymphocyte depletion, especially in the CD4+ subset of T cells, which makes answer A incorrect. Rituximab is an anti-CD20 monoclonal antibody targeting malignant and normal B lymphocytes. Removal of CD20-expressing cells leads to a dysregulation of immune homeostasis, which in turn may result in hypogammaglobulinemia. That makes answer C correct. Kindly advance to the next slide. And the next question reads, JAB, a 47-year-old female patient presents to her personal physician for an annual follow-up. She states that she cannot recall ever having chickenpox or shingles. She has a past medical history significant for type 2 diabetes mellitus, hypertension and end-stage renal disease. She is receiving hemodialysis and is on the renal transplant waiting list. Her herpes virus serologies are as follows: cytomegalovirus, abbreviated as CMV seropositive; herpes simplex virus, abbreviated as HSV seronegative; Epstein-Barr virus, abbreviated as EBV seropositive; and varicella zoster virus, abbreviated as VZV seronegative. Which of the following would be the best to prevent herpes zoster (HZ) in JAB's case? Would it be A. give varicella zoster immune globulin Vari-Zig, or B. give Zostavax, or C. give Verivax 1 dose now and a second dose 28 days later, or would it be D. give Verivax and recheck VZV serology 28 days later? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Give Varivax and recheck VZV serology 28 days later. Varicella vaccine is recommended before transplantation for seronegative individuals. Adult patients should receive 1 dose of the vaccine with VZV serology repeated 4 weeks later, and a second dose of vaccine may be given once if negative. That makes answer D correct. Pediatric patients should receive 2 doses of the VZV vaccine 4 weeks apart. That makes answer C incorrect. Zoster vaccine is approved for adults older than 50 to prevent shingles and post-herpetic neuralgia, regardless of age-Z history, but is recommended by ACIP for adults older than 60. That makes answer B incorrect. The Varizig vaccine is recommended only as post-exposure prophylaxis in high-risk VZV seronegative patients, which makes answer A incorrect. Kindly proceed to the next question. And the next question reads, NCD, a 55-year-old female patient is scheduled to receive a living-related renal transplant from her niece. She has a past medical history significant for type 2 diabetes mellitus, and hypertension. The donor's herpes virus serological profile is as follows: HSV seropositive, VZV seropositive, EBV seropositive, and CMV seropositive. The recipient's herpes virus serological profile is as follows: HSV positive, VZV positive, EBV positive, and CMV negative. So my question to you is, which of the following would be the best antiviral prophylaxis for NCD? Would it be A. Famciclovir 250 mg orally twice daily, or B. Acyclovir 400 mg orally twice daily, or C. Valganciclovir 900 mg orally once daily, or would it be D. Ganciclovir 1 gram orally twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Valganciclovir 900 mg orally once daily. This patient is at high risk of CMV infection because 1. The donor has a history of CMV infection, and 2. The patient has no history of infection and thus lacks CMV-specific antibodies. Valganciclovir 900 mg orally once daily is preferred for adult transplant recipients. That makes answer C correct. Ganciclovir 1 gram orally 2 times daily. Answer D is incorrect. Ganciclovir 5 mg per kilogram intravenously once daily is the other option. Famciclovir has not been studied for CMV prophylaxis. That makes answer A incorrect. Acyclovir may be an alternative but at doses higher than 800 mg per day, which makes answer B incorrect. Please move on to the next question. And the next question reads, JEF, is a 54-year-old male hepatic transplant recipient who presents to the clinic for a routine follow-up. He has no known drug or food allergies. JEF's allograft is functioning well, and he has not been treated for rejection. So my question to you is, since the influenza season has just begun, which of the following would be the most appropriate means of prevention for this patient? Would it be A. Live attenuated influenza vaccine, abbreviated as LAIV, or B. Inactivated influenza vaccine, abbreviated as IIV, or C. Inactivated influenza vaccine, IIV, and oseltamivir 75 mg orally once daily for 14 days, or would it be D. Oseltamivir 75 mg orally once daily for the duration of the influenza season? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Inactivated influenza vaccine, abbreviated as IIV. Vaccination is the most effective method for preventing influenza. That makes answer D incorrect. The inactivated vaccine is preferred for this patient because he is a transplant recipient. That makes answer B correct and answer A incorrect. Use of oseltamivir for 2 weeks at the time of influenza vaccination to provide protection until immunity is established may be considered if a patient has an influenza exposure. That makes answer C incorrect because the patient did not report an influenza exposure. Please progress to the next question. And the next question reads, CGH, a 57-year-old male patient presents to the pulmonary clinic with facial pain and increased nasal output for 7 days as well as a low-grade fever for the past 2 days. He has a past medical history significant for chronic obstructive pulmonary disease, abbreviated as COPD, who received a unilateral lung transplant 6 months ago. CGH has been treated for acute cellular rejection with high-dose methylprednisolone 3 times since his transplant, and he is receiving anti-infective prophylaxis with valganciclovir, cotrimoxazole, and voriconazole. Sinus computed tomography (CT) shows bony erosion. A sinus biopsy reveals non-septate hyphae. The pulmonologist calls his infectious diseases colleague, who recommends amphotericin B lipid complex 5 mg per kilogram IV once daily and surgical evaluation. So my question to you is, with which fungal pathogen is the infectious diseases specialist most likely concerned? Is he concerned with A. Rhizopus, or B. Cryptococcus neoformans, or C. Blastomyces dermatitidis, or is it with D. Aspergillus fumigatus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Rhizopus. The finding of non-septate hyphae is consistent with the zygomycetes, such as Mucor, Rhizopus, or Rhizomucor. This patient's history of several courses of high-dose steroids and recent transplant surgery are risk factors for infections caused by the zygomycetes. In addition, the most common infection site is rhinocerebral, and the zygomycetes are resistant to voriconazole. That makes answer A correct. Aspergillus, though also a mold, would have septate hyphae with acute angle branching, and the patient's voriconazole prophylaxis should be active against this pathogen. That makes answer D incorrect. Blastomyces and Cryptococcus would both be identified as yeast in culture or pathology and would also be covered by voriconazole, which makes answers B and C incorrect. Please progress to the next slide. And the next question reads, KIJ, a 39-year-old female patient underwent an allogeneic hematopoietic cell transplant, abbreviated as HCT, for acute myeloid leukemia, abbreviated as AML. Her initial post-transplant course was uncomplicated. However, 31 days after engraftment, that is, 7 weeks post-transplantation, KIJ developed a fever and rash. A skin biopsy revealed graft versus host disease, abbreviated as GVHD, for which the patient's tacrolimus dose was increased. KIJ also received high-dose steroids, which caused her fever to resolve and her rash to improve. She received maintenance therapy with prednisone 25 mg orally once daily. 30 days later, KIJ presents to the hematology clinic with a worsening dry cough, shortness of breath, fever, and one episode of hemoptysis. Her chest CT reveals a left-sided cavitary lesion. The hematologist would like to initiate anti-aspergillus therapy. So my question to you is, which of the following agents would be best to recommend in KIJ's case? Would it be A. caspofungin, or B. liposomal amphotericin B, or C. voriconazole, or would it be D. itraconazole? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. voriconazole. Voriconazole is considered the drug of choice for the initial treatment of invasive aspergillosis. That makes answer C correct. Itraconazole has anti-aspergillus activity but is rarely used because voriconazole is more potent and has better data to support its use. That makes answer D incorrect. The lipid formulations of amphotericin B and the echinocandins are considered alternatives to voriconazole if the patient is intolerant and/or lacks response. That makes answers B and A incorrect. In addition, isavuconazole was recently approved for the treatment of invasive aspergillosis after a clinical study in which it was non-inferior to voriconazole for aspergillosis. However, voriconazole is still first line in the most recent guidelines. Please advance to the next question. And the next question reads, which organism best fits the following description, is endemic in the Ohio and Mississippi River valleys and may manifest as an acute pulmonary, chronic pulmonary, or disseminated infection? Is it A. Coccidioides posada, or B. Coccidioides immitis, or C. Histoplasma capsulatum, or is it D. B. dermatitidis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Histoplasma capsulatum. Histoplasma capsulatum is endemic in the Ohio and Mississippi River valleys. That makes answer C correct. B. dermatitidis is endemic around the Great Lakes region in the USA. That makes answer D incorrect, whereas coccidioides species are endemic in the desert southwest of the USA, which makes answers B and A incorrect. Please move on to the next question. And the next question reads, OKL, a 46-year-old male patient presents to the Comprehensive Care HIV clinic with a chief complaint of progressive weight loss, high-grade fever, night sweats, diarrhea, and swollen lymph nodes. His chemistries are normal except for mild elevations in his serum transaminases with newly diagnosed HIV infection and AIDS. He has not begun HAART, his CD4+ count is 32 cells per millimeter cubed and viral load is 251,351 copies per milliliter. The infectious diseases physician would like to initiate empiric therapy for Mycobacterium avium complex, abbreviated as MAC, so my question to you is, which of the regimens listed below would you recommend for OKL's clinical scenario? Would it be A. rifabutin plus clarithromycin plus ethambutol, or B. amikacin plus azithromycin plus rifabutin, or C. rifampin plus clarithromycin, or would it be D. streptomycin plus azithromycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Rifabutin plus clarithromycin plus ethambutol. Initial first-line treatment for MAC consists of clarithromycin and ethambutol plus or minus rifabutin. That makes answer A correct and answers B to D incorrect. Azithromycin may be substituted for clarithromycin, and or rifampin may be substituted for rifabutin. Streptomycin and amikacin are alternative agents but not typically given as first-line therapy unless necessary. Kindly progress to the next question. And the next question reads, WMN, a 56-year-old male patient with newly diagnosed AML who is receiving induction chemotherapy with cytarabine and daunorubicin. He is afebrile and has mucositis and mild diarrhea but is otherwise asymptomatic. WMN was born in the Philippines and moved to England at 19 years of age. Given his residence in Southeast Asia, he is tested for strongyloides and found seropositive. So my question to you is, which of the following would be the best recommendation for WMN's clinical scenario at this time? Would it be A. Monitor closely, but do not treat because he does not have fever or eosinophilia, or B. Give ivermectin 200 mcg per kilogram orally once daily for 2 days, or C. Give ivermectin 200 mcg per kilogram orally once daily for 1 to 2 weeks, or would it be D. Give cotrimoxazole 1 double strength, DS orally once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Give ivermectin 200 mcg per kilogram orally once daily for 2 days. This patient should be treated for chronic strongyloides infection, given his positive antibody and exposure history, to prevent hyperinfection because he will be immunocompromised with treatment of his AML and possible need for an HCT in the future. That makes answer B correct, and answer A incorrect. Daily ivermectin for 7 to 14 days is the treatment for hyperinfection or disseminated disease, which is unnecessary because the patient is currently asymptomatic. That makes answer C incorrect. Trimethoprim, sulfamethoxazole has no activity against strongyloides, which makes answer D incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 161.